I'll be taking practice question 8 today. That is going to be a generic competency. So it's advocacy, and this is how the questions go. What is advocacy? That's question 1. Question 2, mention 8 types of advocacy. Question 3, name 3 levels of clinical advocacy. And question 4, take 1 type and conduct an advocacy. Question 5 is name 8 generic competencies that are tested in this college. So the first question, what is advocacy? This is an act or process of supporting a cause or proposal. Or alternative definitions of advocacy include a set of specific actions directed at changing the policies, position, or programmers for a specific cause. Speaking up, drawing a community's attention to any important issue, and directing decision makers towards a solution. And the purpose of advocacy is to promote or reinforce a change in policy, program, practice, or legislation, speaking in favor of or winning support for a cause and others. Question 2 is, what are the types of advocacy? So we have self-advocacy, which is defined as individual's ability to effectively communicate his or her own interests, desires, needs, and rights. They will have patient's advocacy, and individual or organization often do not always concern with one specific group of disorders, advocating for the patient, survivors, and or caregivers. Then group advocacy, people with shared experiences, positions of values coming together in groups to talk and listen to each other, pick up about issues that are important to them. Then we have peer advocacy, one-to-one support provided by advocates with similar experience or experiences, disabilities to a person using a service or services. Then there's citizens advocacy, which involves people in the local community and affords an avenue for them to address and speak to about things that affect or impact on their lives in the community. Then statutory advocacy, that's a situation whereby a person is legally entitled to advocate, usually due to an impaired mental state. Then the last 3 is non-structured advocacy. That's an independent advocate uses information gathered to represent a person who is unavailable to give their views and make their own decisions. Legal advocacy is utilization of the judicial system to advocate for social change goals. Then professional advocacy, that's paid. Independent advocates support and enable people to speak up and represent their views. Those are the types of advocacy. And the next question is, what are the levels of clinical advocacy? So there are 3 levels. It could be patients, which is clinical and paraclinical. It could be practice, that's quality improvement. That's what you're looking for in the clinical advocacy. And then you can be community-based, community or system-based, which can include healthcare activism and knowledge exchange. Then the next question was, take 1 type and conduct an advocacy. So I'll be doing a health advocacy, and the question that I'll be taking will be, there is an increasing prevalence of hypertension with hypertension-related complications at first presentation in your community. Create an advocacy on early diagnosis and screening for hypertension in your local government area in Lagos State. My local government is Mushin local government in Lagos. So I'll be going through the series of sequence of PACOM, which is preparation, alliances, resources, campaigning, organization and motivation and evaluation. So I'm starting with preparation. So there needs to be clarity in the desired change that I want, and how I'll be going about it is that the change I want is early screening for hypertension and people knowing their numbers. That is the change that I want. Since that is the change that I want, I would like to engage the community and build trust. How I'll do this is going to the people that are in the local heads in the Mushin local government, the local government chairman, and the other leaders in the community, which include local business heads and people that are involved in the local healthcare sector in Mushin local government, even those who own local businesses. And thereby I'll be engaging the community and building trust, telling them about what I want to do in the community in terms of my advocacy for hypertension. When I have engaged the community and built trust, then I want to find out from the community, what kind of knowledge gaps are in the community, know the extent of their current knowledge. What do they know about hypertension? What do they know about the sequelae of hypertension? What do they know about blood pressure checks? From this information I get, that's when I'll be able to know how to target my advocacy in terms of hypertension properly. Then I want to identify the stakeholders and gatekeepers of the community. In the community like this, it's the chiefs, it's the head of businesses, it's the local government and policymakers in the community that are the head. So I want to target those people to enable my advocacy to go smoothly. Then I'd like to highlight challenges in the community and discuss challenges and opposition in the community. And one of the biggest ones in my community will be mostly insecurity. Claire, I would like to now at this point have achievable timelines, objectives, have a very clear and concise budget and measurable goals. And after the timelines I have put for myself, which is ideally between 6 to 12 months, I'd like to reevaluate my goals. Then for alliances, I would like to create a team. This will be made up of people of multidisciplinary people with multidisciplinary skills, which include healthcare workers, people that are social media savvy, media in general savvy, those who are involved in healthcare advocacy in other communities that would like to be involved, healthcare professionals in this community, and any other person that would like to be involved in the advocacy that has knowledge of hypertension. And I'd like to put them in different roles, into different teams that will be in charge of different sectors with different team leads. Now I want to identify sponsors and supporters. Then I'd like to leverage my partnerships with pharmaceutical companies, NGOs, and certain local lawmakers to be able to get sponsorship from them, to be able to get the advocacy for hypertension going. Then in between this period also, I'd like to identify my champion, which the champion will be most likely somebody that can use all forms of social media, which include Instagram, TikTok, TV shows, podcasts, and raise their hypertension awareness in upcoming screening days, especially in the World Hypertension Day, which is on the 17th of May. Then I like to use flyers, online ads, talking and engagements in schools, mosques, and community outreach in this environment. And some of the champions can include musicians. One that is popular in this area is Pasuma. Then we also have the House of Rep. There's one Elliot in this area that is very prominent in advocacy in different sectors. Then I'd like to strategize with the leaders in the community also, the LGA chairman, the heads of the primary healthcare sectors, the heads of different community healthcare centers, so that they can be aware of what I'm doing and so I can get in touch with their patients. Then for resources, I'd like to have a clear budget, adequate for the advocacy, which include the location. What do I want to do? Do I want to do a screening program? I'd like to get location, equipment, transport, medication, a clear, concise budget. Then I'd like to engage humans because in resources, it could be human. So manpower, it could be financial, in cash on kind, it could be public or it could be private, like I mentioned before. Or it could even be organizational, which we have CSR, corporate social responsibility of many companies in which they're able to donate to different causes, of which I'll propose my cause to them and hopefully get sponsorship from them. Then I also educate my sponsors about what I'm doing about advocacy, about early hypertension detection, so that I can get long-term sponsorship from them. Then my budget will be very clear and transparent, even to the sponsors and to the team and to everybody that is involved in the advocacy. Then we'll go down to campaigning. And I like to put up a mission statement for the campaign, which includes measure your blood pressure accurately, control it, and live longer. Activities during the campaign will be targeted towards the type of audience that I'm getting involved with, which during the advocacy or the screenings or the outreach that we'll be doing, there'll be quizzes on hypertension after to be able to evaluate with gifts, to evaluate the community, whether they have actually understood the message that has been passed on. And we'll get some of the celebrities, which I mentioned about, to be able to talk about their experiences and on hypertension and possible complications. Then there'll be good set timelines for coordination between team members also. Then for organization, this will be involved between the team. So we'll have meetings, training in advocacy for hypertension with each team member so that we know what exact knowledge base each team member has. Then I'd like to do a quick SWOT analysis. So a quick SWOT analysis, especially for organization, will include the strengths. Strengths, that's going to be the first thing. What are the strengths? What do I have? I like to evaluate all the things I have and my strengths. Then for weaknesses, I like to evaluate, okay, what are the type of manpower that would I like? What kind of manpower do I need that I don't have? What are the kind of resources that I need that I don't have? That'll be part of my weaknesses. Then for opportunities, what are the things that are going on in this community? Like local shows, conferences that I can leverage on rather than going out on my own and do my advocacy in those venues. Therefore, threats, things like social, like insecurity, things like conflict of interest between sponsors, things like inbreeding, between team members, miscommunication between team members. How would I will address all those threats to my organization? Then in between this, I would like to strengthen my network between the team, the local government, the sponsors, and the leaders. So everybody will be able to meet in meetings and be able to strategize together. Then for monitoring and evaluation, this can be quantitative or qualitative. So you want to know the effects of the advocacy. I want to know the effects of advocacy that I have done. I like to do this via questionnaires, questions to the audience, post-screening. Then if I meet people that have hypertension, that they are newly diagnosed, refer them to primary healthcare centers, refer them to a tertiary center like mine, then I want to get feedback on those people who have actually come post-screening. That's going to be part of my feedback to know the effects of my advocacy. Then the data during this screening and outreach also can be taken and also used to buttress the point about the need of more screening programs for hypertension. All of this can also be used to increase motivation between the advocates and the sponsors. So the last question is the name 8 generic competencies tested. This will include health administration, that's managing of health and medical facilities, then advanced general medical knowledge, management of acute and chronic diseases, clinical decision-making, which can be diagnostic, investigative, and therapeutic, communication skills, which can be doctor to patient, complaints procedure, breaking bad news. The next point is conducting biomedical research, which can be planning, analyzing research projects, applying for grants. Then we have clinical governance, which can include risk management, evidence-based medicine, audits, then lastly, health advocacy. Thank you so much, everyone, for listening. I'll be taking questions, comments, and suggestions. Thank you, everyone.
Thank you, Dr. Precious. Thank you. Well done. It's a very good one. We'll entertain comments from the audience, please. Thank you. Any comments? Okay, sorry, maybe before other people's comment, I have one thing. Thank you, it's really a very good one. I don't know, human resource management, is it part of this generic competencies? And
Yes.
medical information, I just want to know, sorry.
No problem. It is part of it. There were so many. They're almost like, okay. There were so many on the slide. So I picked these ones in particular, but okay. There is a list I have. Maybe I'll put it on the group, but let me get it for you.
So maybe we need to have all the generic competence, then those that were tested by National Postgraduate Medical College.
Yes.
Maybe
This
like
ones are
the question narrowed to those tested.
These ones were the ones that were tested, and the last that
okay.
Dr. Professor Oguni said that are normally tested.
Okay.
Yes, these are the most important generic competencies that I put up there.
Okay, thank you. Thank you.
All right.
Any other question, comment, clarification?
Mm-hmm. All right.
Okay. Okay.
Right.
Sorry. I also have a question.
Please go ahead.
Yes. Please, at what point are you going to invite the head of your institution, like the CMDs, the CMAC, the admin, Are they really important in this, and at what point? Is it at the level of preparation or alliance?
All right. So that is very important. Thank you, Dr. Yahaya, for your question. So that's very important. If I was doing the advocacy in my hospital, maybe, but I was doing a community-based advocacy. That was why I involved mostly the local government chairman, and people that were involved in the businesses in the local governments and the healthcare sector in the local governments. I was doing it at the community level. Maybe that's why I didn't involve them. I don't know if I was supposed to call my...
You're supposed to involve them.
Okay, I'm supposed to involve them. Okay.
Yes, you're supposed to involve them. No matter what you're doing in your community, hospital or not, remember, if you're doing research, you could still take ethical clearance from the hospital, even if it's community-based research. Remember that. So even at that, the CMD has to come in. A representative of the admin has to come in, and even somebody in the finance department has to come in. Then somebody in the state or community financial department has to come in. These things has to be sponsored there. Even if you are starting with sponsoring from your pocket, you cannot continue sponsoring from your pocket. You need sponsor from the government. You need sponsorship from the hospital. So they all have to come in, and even if they're going to make, you are doing advocacy for the laws to change, for people to, for this whole thing, for people to know these things better, and for it to be made into a law in a way. So the government has to come in, the hospital, because need all the support from everyone available. So they're actually important. And they will know you didn't mention that. But thank you so much, Yahaya, for highlighting that.
Thank you, ma'am.
Thank you, Chief. Thank you, Dr.
Thank you, ma'am, for the clarification. Thank you. Hold on. We still entertain some few more comment questions before we move to the next part of the presentation.
We might have to, let me just make my comment. Let us move.
Yes.
Answers more. No, we're still coming from holiday, so any party. But the professor did a wonderful job, and she had this nice, soothing voice, and she did so well. So I guess that's why many people don't have any comments. She did well. But what I want to emphasize, it was what Prof. Olatunji said one time. Now, if you observe, they are beginning to ask list, define. This pattern of the exam has changed. They no longer they really don't do list anymore. It's more of applications of some of this knowledge. If you see list, it's not so common. So you might not see list 8 common competencies in the college. I doubt you will see a question like that. So all these questions you presented, those going for the exam, please go and look at the application of this knowledge. National has moved from lists. They're no longer in secondary school. They've moved from lists to application. They will create a clinical scenario and ask you to apply this knowledge you should have known. So they are now more into application of knowledge. So she discussed advocacy, and she discussed competencies in internal medicine. So go back and ask yourself. I know she did an application. She answered the question on application of clinical advocacy. So that's fine, and she did so well. Then the other aspect of competencies in internal medicine, just go through all the competencies in national and ones that they release in their updates, and even the ones they did not put in their update course, because they can bring a question that you need to apply a knowledge on these clinical competencies on. So that's just what I want to add. That Dr. Precious did a wonderful job. She did a wonderful job. So I think if there are any comments, I believe by now we'll have seen them. So please, let's move to the next presenter. Thank you, Dr. Precious.
Okay.
Thank you, Dr. Yahaya.
Thank you, ma. Thank you, ma, for the addition. Thank you. I think the next is either she present her first question or Dr. Alatu will complete the last May 2022, the last question. I don't know. I think we should take Dr. Alatu's.
Complete that.
Yes, ma'am. Okay, go ahead, Dr. Alatu.
Okay. Good morning, senior colleagues and colleagues. I'm presenting practice question 11. The question says, a 20-year-old lady with lupus nephritis attending your facility. Question 1, list and explain the steps in clinical audits. What component will you audit? List 6 components you assess to ensure that she gets adequate care. What are the 3 lab investigations you will encourage the management to make available for disease monitoring? Mention 5 drugs with their mode of administration. These are the steps in clinical audit. We identify the problem. We define standard. We take data, we analyze data and make an inference out of it. When we compare it with the standard, we identify the gaps and then we implement the changes. Then we audit the process again. So these are the 6 steps in clinical audit. The steps we identify the problem, determine the specific aspect of clinical care to be audited, such as a particular condition or a process or the outcome. And then we establish a standard criteria. We define the criteria and the standard against which the audit will be conducted, often based on the clinical guidelines, best practice, or evidence-based medicine. And at that time also, we make adequate preparation and know the particular stakeholders to involve in the audit process. And we may attempt to get to involve the hospital research committee, where they may waive the ethical clearance. And then we begin to take data. We gather relevant data from the patient record database, other sources to assess adherence to establish criteria or standards. And then after we must have done that, we move for data analysis. We analyze the data, identify areas of potential improvement or deviation from the expected standard of care. Then give a feedback to the management and recommendation. Present the findings to the relevant healthcare professional and stakeholder, discuss the result and make recommendation for change or improvement in the clinical practice. Then we begin to implement. At that point, the hospital management will give us go ahead to implement the changes, then implement changes and all the necessary changes we implement there and give it time, say 3 months or 6-month period, and then we audit the process again, and then the cycle continue. Then what component will you audit? Looking at this patient, the case is that of 20-year-old lady with lupus nephritis. They decide to audit the process of care. The components, list 6 components you assess to ensure that she gets adequate care. The component is the adherence to the established treatment guidelines, including the diagnosis and classification, verify from the record whether she was adequately diagnosed. We look at the ACR criteria, whether she fulfilled the criteria, and then we get correct whether she's correctly classified. And then we ensure the patient is receiving the care in line with the established guideline for management of lupus nephritis. Then the next one is regular monitoring of renal function. We assess whether how frequent she been screened for the renal functions, appropriateness of renal function monitoring, including serum creatinine, serum proteinuria, we also proteinuria, and then urinary sediments. So we do urinalysis, how frequent she is doing urinalysis, how frequent we assess the serum electrolyte and creatinine, as well as bone mineral disease. Then the next one is appropriate use of immunosuppressive medication. We evaluate the selection and dosing of immunosuppressive agent based on the disease severity and individual patient factor. Whether she needs the dosage, is it adequate for her, or we are underdosing her, or we are overdosing the patient. And also the side effect of this medication will be assessed, whether we are monitoring the side effect of the medication or not, especially if we are using methotrexate and then she's a 20-year-old lady at the reproductive age group. We verify whether she's been counseled for contraception and what's the plan for pregnancy, whether she's married or not. So we assess that during the data collection. Appropriate use of immunosuppressive medication, evaluate the selection. I think I mentioned that one. Then the blood pressure control. How regular, how well is her blood pressure control over the period from the onset of care and to the time we are doing the audit. And then the common a common complication of lupus nephritis is hypertension, and then we minimize renal damage by monitoring the blood pressure. Then screening for complication, we ensure that the patient is being screened for potential complication of lupus, such as infection. Infection is very common in patients with lupus nephritis, and then cardiovascular diseases and osteoporosis. So we identify whether she's being assessed for these conditions or not. And then we looked at the patient's education and support. We have an in-depth interview with the patient and probably a caregiver, whether they are aware of the disease condition, evaluate the provision of patient education and support, the patient regarding medication adherence, lifestyle, and self-care management. The next question is, what are the 3 lab investigations you encourage management to make available for the disease monitoring? Complete blood count is important for monitoring of these patients. Some of them, they present with anemia, leukopenia, and even thrombocytopenia. So complete blood count tool is important in monitoring this patient's condition. Kidney function tests, especially the creatinine and blood urea nitrogen, to assess renal function and monitor the disease progression. Then urinalysis for proteinuria and hematuria to monitor the kidney damage and also disease severity as well. Other things like the histopathology that should be available when there is need for kidney biopsy and staging of this patient appropriately. Mention 5 drugs with their mode of administration. Some of the drugs that we use include the steroids, like methylprednisolone. The mode of administration in intravenous injection. Prednisolone is oral administration. Mycophenolate mofetil is oral in tablet or in capsular form. Cyclophosphamide may be administered orally or intravenously, depending on the treatment regimen and then the disease severity at that point. Tacrolimus is oral administration, is being administered orally. Hydroxychloroquine is also oral administration. Then we have the biologic rituximab administered intravenously. Angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers, they are administered orally to control hypertension and renal protection. Thank you very much. So this is a very short presentation. Entertain comments, questions, and corrections. Thank you.
Thank you, Dr. Alhatu. It's a good one. Thank you, all done. As you said, we entertain comments, additions, and some clarifications, if any. Okay, Dr. Al, maybe I'll start. Thank you very much. It's a good one. The steps you followed, even though I have another ways of following that, and it's like whatever the step 1 followed, to some extent, they explain each other. So I just want to ask, which one should we stick to, or is we can follow all? And like the one I know is prepare and plan, under which you set up a team, you define the problem, then you select a component that you are going to audit. Then you define the standard criteria, you measure the performance, you improve the performance, and you sustain the improvement. And subsequently, if there is need for auditing, you do that. So I just want to ask, should we follow this, or they are, even though, as I said, it's like they explain all of them. The target is they explain almost everything. So that's my first question. Chief Dr. Fatima want to help. Please go ahead, ma.
Yeah, thank you very much, Dr. Belhatu, for that excellent presentation. I also had a similar thought as you, Dr. Haya. Regarding the first step, you mentioned identify the problem. It's not that it's not a land, but if you use a prepare and plan as your number one step, on that prepare and plan, you set up a team. I didn't hear you talk about setting up a team. You can't do a clinical audit alone. So you have to set up a team involving the rheumatologists, the nurses, the pharmacists, the labs, and all the people that are involved in the management of the patient. They need to be part of the team, as well as the hospital administration, the CMD, the CMAC, the director resources, because you can't do a clinical audit without resources. You need resources. And whatever change you identify that need to be implemented, without the hospital management involved, nothing will happen. So it's very important to set up a team. Setting up a team is very important. You identify the problem and communicate the problem with all the team members so that they are all aware of what exactly you are doing. If you remember, communication is key in teamwork. Without communication, nothing will, no effective, without effective communication, you will not achieve your goal. So on that prepare and plan, you set up a team, identify the problem, then communicate the problem, communicate with all the team members so that everyone is aware of what exactly you'll do. Then the next step is you set a standard criteria. This is where you choose either a local or a national guideline, a guideline that is applicable, not that you choose a guideline that at the end of the day, you can't meet up with it. Although you may not be able to change what you are doing to 100%, just exactly as the guideline, but choose a guideline that is applicable, something that is feasible, not something that you can never reach. So apart from certain standard criteria, then you measure your performance. This is where you collect data, then you analyze the data and compare the data with the standard guideline that you choose. So that is how you will get to measure what exactly you are doing. Are you doing 40% or 50% of the standard? So this is where you identify the gaps in practice. Then you bring about the change. This is where you involve the hospital management, making them understand how far you are from standard. This is why you are not achieving, you are not getting a good outcome also, so that the hospital will understand, yes, you really need to bring about change. Then the change will be implemented and allow time. So that is my comment regarding this. Well done, you did well.
Thank you, ma. Thank you very much. Thank you.
Thank you, ma.
Okay. Another thing, Dr. Alatu, regarding the 3 lab investigation for disease monitoring, yes, food blood count, EUCR analysis, they are good. I don't know, these patients, sometimes they used to have flare. Can we add other ones that we do that will make the management to make it available? Those that will check for the flare of the disease, like ESR, like anti-double-stranded DNA, and the complement. Complement used to be low, and ESR, anti-double-stranded DNA level tend to rise if they have flare. I don't know. I agree with quite sure that for the monitoring, the most important ones you require are those of food blood count, EUCR, and urinalysis, as you highlighted. So I just want to say, can we, others, like in case of flare, maybe ESR, anti-double-stranded DNA, and the complement level. Thank you very much.
Yes, we can include them. Most of the immunological tests and even the histopathological tests could be involved. Thank you.
Thank you. Please, any other comments, addition?
Yeah, it's important to include all those because sometimes if you tell them the investigations, if they didn't hear the one that is on their checklist, they will be asking you what more, what more, what more. So no information is a waste. Just carry all that information along.
Thank you, ma. Thank you. Well done. Chief Shitu want to say something to us. Go ahead, sir.
Oh, Doctor. I don't know who presented. Well, I didn't start at the beginning. I was asked to ask, was it just SLE as a whole, or was it lupus nephritis that we were auditing?
That the question is lupus nephritis. Maybe Dr. Alatu, can you share the question?
Hello?
Back?
Oh, okay. Was lupus nephritis? Okay.
Yes.
Now, two things. First thing I want to do is I want to reinforce what Dr. Fatima said. You mind, Dr. Fatima? When she pointed out the fact that you have that audit mentality, because the first thing you're going to do, the first thing that team is going to do is to even do this. Is the appropriate to go about the problem. Okay, so if you don't have a team of all this, like you really particular problem, I mean, you could actually include a patient to have that particular disease entity. You can include one of them. Now, for lupus nephritis, because lupus nephritis is basically an offshoot of the SM in getting the patient, you have to do things you use to investigate this as a whole, and then things you use to investigate the particular complication.
Sir, the line is breaking. I don't know if I'm the only one.
Monitor improvement in the. Hello? Hello?
Your line is breaking, sir. It's difficult to understand what you are saying.
Oh, it's breaking up. Oh. Let me change networks. I suspect maybe the network may be the problem.
Okay. Now it's better as you are talking.
It's becoming clearer.
Hello? Hello?
We can hear you, sir.
Hello?
We can hear you, sir.
Oh, it's better now. Is it still breaking up, or it's better?
I think it's better, sir.
It's good. It's good. Better.
Or it's still breaking up a bit. Okay, lovely. Thank you. Yeah, so what I was saying was that because it's systemic lupus erythematosus, and of course, the person is manifesting with lupus nephritis. Of course, you know that 20% of patients with SLE, their first manifestation will be lupus nephritis. So it's actually a very important question. You have to do tests that would monitor both the SLE as a whole and then the specific problem, which is lupus nephritis. Okay, so in making your diagnosis, apart from all your serological tests and everything, it's important that you need to have a kidney biopsy done that will help you determine the stage and the medications you use to treat the patient, because we do know that people in stage 3, stage 4 are the ones that we tend to go all out with our immunosuppressives. Patients with 1 and 2, 5 and 6, well, they may not really respond so well to immunosuppressives when given. So it's important to state that. Then when you're monitoring your patients, it's important to have either protein creatinine ratio or albumin creatinine ratio, or some way of monitoring the protein loss. And then of course your EUCR, okay, as well. Many of them may have a normal EUCR, okay, but it may be the proteinuria that is the thing that made you classify them as lupus nephritis that made you go ahead and do a biopsy for them. Then I said earlier that when putting what Dr. Fatima said about putting a team together is very important, because if you don't put a team together, the first thing that the team is going to do is to determine if a clinical audit is the way to go in solving that particular problem, because everything starts with a problem. Okay. So that team must first think about it and say, okay, fine, the clinical audit is the way to go, and then pick a component. Now, in the question somewhere, they said, you know, what component would you audit? I don't know if there was a addition to the question apart from what is in front of me, okay? Or there were extra things to do, but things that are rare, like SLE, the problem many a times is not the process. The problem is the structure. Because you need specialist care, you need specialist equipment, you need specialist drugs, you need specialist labs, okay? It's always easier for rare things to have, for you to look at structure, okay? Do you have the manpower? Do you have the materials? Okay, and things like that. Do you have the money? It'd be easier to audit structure here. And auditing the structure, what you're looking out for are all those things that I've mentioned. All those. Do you have the staff to look at it? Do you have the drugs? Do you have the equipment to carry out the necessary lab investigations? Do you have the necessary things to follow up the patient and things like that? So you may want to audit structure here rather than process. Now, if it was a common thing like hypertension or diabetes, you know, that many hospitals are already equipped with the way of process, okay? But rare things like this, you may want to go structure because you need specialist people and equipment. Also, you would, I think Dr. Fatima also pointed out that, I'm trying to remember now. Oh, yes, picking your standard, okay? You can either pick a local or international standard, okay? But there are very easy guidelines for lupus nephritis, so you could use international for that. And yes, you have to say to what extent you want to follow that guideline. The guideline now will be telling you to check something every hour, for instance, okay? And you may not be able to afford to do that. Patient may not be able to afford it. You may have to stretch it. But you want to get as close to 100% as possible. So you may say 80, 70%, 80%, okay? And things like that, okay? So you have to pick the extent in which you're going to go ahead and do it. The final comment I want to make is about the drugs. He didn't mention mycophenolate mofetil, which is very important in lupus nephritis. Cyclophosphamide, I didn't hear cyclophosphamide, also very important. Azothioprine, very important. If we look at the various guidelines that we use for managing lupus nephritis, whether it's KDIGO, Euro lupus, and all the other guidelines, about 3, there are many of them. Based on certain find out that these are the drugs that are your methylprednisolone, which is the IV version of prednisolone, and of course your oral prednisolone much later on, okay? And things like that. So I just wanted to add those comments. Yes, thank you.
Thank you, sir, for this wonderful contribution. Thank you. I don't know if there is any other. Maybe Dr. Priscilla, any other thing?
Sorry, good morning, everyone. Good morning, senior colleagues and colleagues. Just a question for Dr. Shito. I think, I don't know if you can recap it. I know for pregnant ladies, there's a particular immunosuppressant we don't give. I can't remember which exactly we don't give. I don't know if you can help me out. Thank you, Dr. Shito.
We don't give MMF. we don't give MMF. We don't give cyclophosphamide. But I think azathioprine is safe, but I can't remember. But I've not treated any pregnant women. But of course, you know that one rule of patients with SLE is that, of course, anyone on MMF, cyclophosphamide, things like that, you have to put them on immunosuppressives. You have to put them on contraceptives because of those particular immunosuppressives. They tend to be teratogenic. But for pregnant, if it occurs during pregnancy, many a times they'll load them with the methylprednisolone. Depending on the stage of pregnancy, if it's early pregnancy, we could actually make a play for termination so that you can actually treat whatever you're treating. But if they insist on keeping it, then you most likely will switch them to things like azathioprine and then see if the patient does well. Of course, with monitoring the baby and the, of course, levels as well. But we don't use too much TAC in treating patients with lupus nephritis. We tend to not to use too much TAC. Well, in this environment, we don't use too much tacrolimus because monitoring it is another issue on its own, okay? Because you have to make sure the TAC levels are appropriate and not overboard. If not, TAC will also destroy the kidney itself. Yes. So I think for pregnant, we usually avoid pregnancy altogether. And then depending on the stage of pregnancy that the patient comes in, if it's about to deliver, we can start steroids and then try and see if we can get the baby to viability and deliver. But if it is really early, then we may just give the option of therapeutic termination. But if the patient says no, then you can now decide on giving azathioprine instead. Although azathioprine is not very good for initiating immunosuppressive, it's good as a maintenance, but not very good as an initiator. Most of the initiating drugs are not safe in pregnancy. Yes.
Oh, okay, what about hydroxychloroquine? Because
Yeah.
most times this lupus nephritis is
Yeah.
silent, then pregnancy is not like a flare. So most people I've actually seen actually came pregnant, and I think they were managed till they give birth. So that's what I'm trying to ask because I can't remember again.
Yeah,
Thank
so you can actually give hydroxychloroquine. Everybody should be on hydroxychloroquine. Anybody with SLE, regardless of the manifestation, regardless of anything, anybody with SLE is supposed to be on hydroxychloroquine. It's the only universal drug with steroids, of course, that we give everyone. Okay.
Thank you.
And I think it's safe in pregnancy. Hydroxychloroquine doesn't have any issues with pregnancy. Just like how you can give chloroquine to a pregnant woman. So it's safe.
Thank you.
Thank you. Thank you, sir.
Hello?
I think we hand over to Dr. Saba. Thank you very much.
Okay, thank you, Dr. Yahaya. Thank you, Dr. Dahatu. Thank you. I must appreciate Dr. Precious, Dr. Dahatu for quite a lucid discussion this morning. Thank you so much. And our facilitators, Chikuki, Chitu, Fatima, Okopi, and our success. Thank you for coming to class. We appreciate your presence and your input. So we continue tomorrow. Thank you, participants, also for coming to class. Those that are celebrating. So we continue tomorrow.